So we will be live in 5, 4, 3, 2, 1. We are live now.
Good evening to all our viewers of OrthoTV. A warm welcome to you all on this auspicious occasion of Ganpati. We are here with the 10th episode of our series on controversies and consensus in orthopedics, what we need to know. This series is being conducted bi-monthly every Wednesday evening with a new and hot topic in each subspecialty of orthopedics under the chairmanship of Dr. S.S. Mohanty and Secretary Dr. PHADNIS, Dr. SWAPNIL, KENY, and myself, Dr. DEEPAK GAUTAM. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at SCFE Medical College and KENY Hospital, Mumbai. He is also an honorary consultant at Ashok Nanavati Hospital. He is the past president of Indian Arthroplasty Association and Bombay Orthopaedic Society. He is a great academician and researcher, the education chair of Indian Society of Hip and Knee Surgeons, reviewer of our famous journals, Bijlani, Ashok, and our own Indian Journal of Orthopaedics. Today is the day of controversies in pediatric orthopedic disorders. We have our eminent speaker, Dr. VENKATADASS from Coimbatore, and moderators, Dr. MANOJ PADMAN from New Delhi, Dr. ANIRBAN CHATTERJEE from Kolkata, and our own Dr. RUJUTA madam from Mumbai. I would now like to call upon Professor Mohanty to introduce our speakers and the moderators and proceed with the session. Dr. Mohanty, sir.
So, good evening, dear friends. Greetings from Mumbai and welcome to the 10th episode of Controversies and Consensus in Orthopedics. Today's episode has been devoted to pediatric orthopedics, and we have, 4 eminent pediatric orthopedic surgeons here who will sweep us through the controversies in, subcapital, slipped capital femoral epiphysis, management of slipped capital femoral epiphysis in children. Our invited speaker today, Dr. VENKATADASS K, who is the head of pediatric orthopedics at Ganga Hospital, Coimbatore. Dr. VENKATADASS is a treasurer of POSHI, Pediatric Orthopedic Society of India, and affiliate member of POSHNA, that is Pediatric Orthopedic Society of North America. He is the associate editor of Indian Journal of Orthopedics and reviewer of Indian Journal of Orthopedics, Indian Journal of Pediatric Orthopedics, and Journal of Clinical Orthopedics and Trauma. And Dr. VENKATADASS has done his hip preservation fellowship from Reddy Children's Hospital at San Diego, United States, and he was part of the research team that won the Eurospine Award in 2008. He has achieved the IOA Young Ambassador Award in 2016, IOA Silver Jubilee Oration in 2018, and of course the POSHNA Course Scholar in 2019. He has several international publications and 3 book chapters to his credit, and his interests include pediatric hip disorders and pediatric trauma. And today's topic is devoted to pediatric hip disorders. So welcome, Dr. VENKATADASS, today, and thank you for devoting time for the teaching of controversy and consensus in orthopedics. Our moderators or moderator, Dr. MANOJ PADMAN, is the director of Center for Pediatric Orthopedics and Disabilities at CPOD New Delhi, and he's the director of head of pediatric orthopedics at Rainbow Children's Hospital in New Delhi and Fortis Memorial Research Institute at Gurgaon as well. He, after finishing his graduation and post-graduation from JIPMER Pondicherry, he has more than 25 years experience as orthopedic surgeons in India and United Kingdom. He has been fellowship trained in the UK in pediatric orthopedics and trauma surgery at Sheffield Children's Hospital, and he manages all aspects of pediatric and adolescent orthopedics, and he has special interest again on the pediatric hip pathologies, limb reconstruction, and deformity correction. Welcome, Dr. Padman, today to this webinar, and thank you for joining today in this webinar and devoting your time for the academics in controversy and consensus in orthopedics. Our next moderator is Dr. ANIRBAN CHATTERJEE. He's senior consultant at hand and pediatric orthopedics from Kolkata, and I am proud to say that Dr. ANIRBAN is a KM Ortho alumni, and he has finished his MS Ortho from KM Mumbai. He did his Fulbright fellowship in hand surgery from famous Wrightington Hospital, UK, and pediatric orthopedic fellowship from National University Hospital of Singapore. And he did his BOS traveling fellowship in hand and microsurgery at Ganga Hospital as well. He has been member of various societies like ISSH, POSI, Aortrauma, IOA, and WOA as well. So welcome Dr. Anirban to today's webinar on controversies about slipped capital femoral epiphysis. And last but not the least, we welcome Dr. RUJUTA MEHTA, who is the head of pediatric orthopedics at Bhai Jerwai Wadia Hospital for Children in Mumbai. She is a consultant at pediatric orthopedic surgeon at Nanavati, Jaslok, and Surya Child Care in Mumbai as well. She is the chair of WISE, that is the Women Orthopedic Surgeons Wing of Indian Collective Empowerment of IOA. And she's the chair of WAPES as well, Women of APOA Advocate Education and Support. She was BOS Secretary in 2018 to 2020, Vice President in 21-22, and probably soon in coming years, she is going to take over as the President of our prestigious Bombay Orthopedic Society as well. She is the section editor of Pediatric Orthopedics, JO, IO, JO, and Journal of JO Rep, Wadia Journal, etc. And she is on the editorial board of IJPO as well. And she is a reviewer of JPOB. Welcome, Dr. RUJUTA, to this episode, and she has been a strong supporter of controversy and consensus in orthopedics. Previously, she has delivered also on about controversies of clubfoot management in this forum. Thank you, Dr. RUJUTA, for your time, and welcome to this episode of Controversy and Consensus. Friends, without any much ado, let me hand over the proceedings to Dr. VENKATADASS to share his screen and tell us about the controversies in slipped capital femoral epiphysis. Thank you.
Thank you, Dr. Mohanty. I would like to thank the organizers for this opportunity, and today I have taken up a very controversial topic, which is slipped capital femoral epiphysis. And I'll try to cover certain important aspects, starting with what do we mean by stable and unstable slip, then the management of unstable slips, stable slips, and a little bit about where do we stand with prophylactic pinning today. So let's start with the unstable slip. Do we have a clear definition? Unfortunately, the definition of unstable slip given by Lauder is no more very clear. So this is the original paper which was published by Lauder in 1993. If you read it, the first line says that it is classified as unstable if the child had such severe pain that walking was not possible, even without crutches, regardless of the duration of symptoms. It looks to be a very clear definition, but in the next line, he defines stable as if the child is walking and weight bearing. So he brings about one more parameter, which is weight bearing. So let us take this scenario. If the child is not able to walk, it is unstable. But if the child is able to walk, he calls it as stable. And if you bring in one more parameter, whether the child is able to weight bear and walk, if the child is able to weight bear and walk, obviously it is stable. But if the child is not able to weight bear but still able to walk, we do not have a definition based on Randy Lauder's classification. So let us look at this child who presented to us about 2 weeks after the onset of symptoms. And she's walking like this. She's taking full weight on the affected limb and she's able to walk. But can we call this as a stable slip just because she is able to weight bear and walk? I don't think so. So how do we define stable slip today? So for me, I think we have to change the definition. We have to look at various parameters. We cannot take just one parameter and say that whether the slip is unstable or stable. So preoperatively, clinical examination, acute aggravation of symptoms or acute onset of symptoms, and unable to weight bear and walk comfortably. So if you look at a stable slip patient, he'll be able to walk comfortably and come into your OPD. And in the X-rays, you'll have gross displacement. Usually, you can see that it's like a fracture neck, acute fracture neck of femur. It separates, and there is a sharp demarcation. And usually, you don't see a lot of callus in an acute unstable slip. Intraoperatively, when you see the hip joint under image intensifier, there could be change in the position of the epiphysis, which is again a subtle indicator for us that it is an unstable slip. And there could be freely mobile epiphysis intraoperatively when you're opening up. And hemarthrosis, again, is one of the other parameters which indicates that the slip could be an unstable slip. So let us look at this example, a 15-year-old boy who comes with a severe pain in the left hip with following a trivial fall, and he presents like a typical unstable slip, brought on a wheelchair and things like that. So what are all the current controversies when you get a patient with an unstable slip? So do we need an advanced imaging? So that is the first controversy which we need to think about. And when do we intervene? So if you get a patient in the middle of the night, should we take him into the operating room immediately, or can we wait? So that is the second controversy which I would like to touch upon. The third one is the most important, which is whether you do a reduction or do an in situ screw fixation, which is considered to be even today the gold standard of management of unstable slip capital femoral epiphysis. As far as advanced imaging is concerned, CT or MRI helps in knowing the chronicity. So it will help us to know whether this is an acute on chronic slip or a pure acute slip. You can see the callus on the posterior aspect and the inferior aspect, which can give the clue. And bone scan, again, it gives the clue on whether the epiphysis is viable or vascular or not. So these are the advanced imaging which is available. And there are centers across the world which practice different ways of imaging. But in our practice, we don't do any advanced imaging for a straightforward unstable slip capital femoral epiphysis because it does not add anything to our management. And I don't think it is of great value to go ahead and do a CT or MRI or a bone scan in an unstable slip situation. Next is timing of intervention. So there are a lot of studies been published in various journals which have shown that if you intervene less than 24 hours of time since the onset of symptoms, the AVN rates are less. But in our experience, we have found that does not really change, and there is no difference in AVN rate because we do get patients who are presenting later, like the video which I showed, it is like two weeks after the onset of symptoms. So, and we found that there is no difference in AVN rates even if you do it after 24 hours or before 24 hours. And our protocol right now is even if we get the case at middle of the night, we wait till next day morning and do it the next day morning. So do it as early as possible and not as an emergency is what we follow. And the last one is whether to do a closed reduction for an unstable slip. This is the biggest controversy. There is no strong evidence which is for or against a reduction in an unstable slip. And there is no clear consensus even today. So this was a paper published in 2006 by Loader. Again, the topic says it's controversies in slip capital femoral epiphysis. And 15 years down the line, still the controversies are remaining the same. That's what I feel. Because one of the reasons is that the condition is quite rare and we don't have huge evidence to generate strong evidence to say that this works and this doesn't work. But what he quoted is the unintentional reduction does not seem to increase the risk of AVN. This was in 2006 by Loader. And this is a more recent paper which was published in 2021. And they have treated about 48 unstable slips. So their protocol was to do a purposeful reduction on a fracture table. And they have shown that it appears to be a reasonably low morbidity option in treatment of unstable slip without clear increase in the risk of AVN, because they say that their AVN rate is 26%, which is comparable to any series in the world which has published on unstable slips. So I'm showing this paper not to encourage all of you to go back and reduce an unstable slip on a fracture table. So that is not the idea of showing this. I am totally against doing a fracture table reduction for an unstable slip. I don't reduce at all. So the idea of showing this is that not all unstable slips which are close reduced go on to have an AVN. So you can see that only about 25 to 30% of them have AVN, and I don't think it has got anything to do with the reduction maneuver. So if you understand the pathology, how an unstable slip happens and how you can safely reposition it, then probably there is definitely a role for a controlled repositioning. So what about open reduction for unstable slips? It is also called as a capital realignment procedure or modified Dunn's procedure. So this was came up in early 2000s, like the first publication was in 2008 or 2009. And in the last 1 decade, there is a lot of papers from various institutions around the world about the use of modified Dunn's procedure in unstable slip. The problem is it has got a steep learning curve and fraught with high complication rates. So this is the first publication in 2009, the technique paper, which was published in COR. And so this is I'm not going to the details of this. And following that, you can see that 2011, 13, 16, 17. So there are a lot of papers which was published on the modified Dunn's procedure. So this is a paper which was published in 2018 from the Boston group. So they do a lot of open hip procedures, surgical dislocations and stuff like that. And they said that the theoretical advantage of preserving the blood supply to the femoral head with a modified Dunn procedure and reduction of osteonecrosis was not observed. So this was the conclusion of their study regarding modified Dunn procedure for unstable slip in a short term. So if you look at the overall treatment trend, you can divide the treatment of unstable slips. So as the era before modified Dunn and after modified Dunn, because before modified Dunn, people were talking about in situ screw fixation versus positional reduction or gentle reduction or whatever you call it. But after the advent of modified Dunn's procedure, it is always between whether it is in situ screw fixation or a modified Dunn's procedure. So nobody talks about the role of positional reduction or a gentle reduction. So we conducted a survey among POSI members. This was like few years ago. And we sent out questionnaires regarding slip capital femoral epiphysis. And we found that so 70% of the surgeons responded that they would do a reduction in an unstable slip and 23% would do a Dunn's procedure, which means indirectly that the other 7% probably will choose an in situ screw fixation. So this was like few years ago. I think it was in 2013, 14 or something like that. And I'm sure if we do the survey again now, the rate will get reversed. I think 70% of them will choose Dunn's procedure and maybe like 20-25% will go for a positional reduction. So let's start with the case example. This is a 14-year-old girl who presented with an unstable slip. She was able to walk with crutches. This was done many years ago, close reduction and screw fixation. And you can see that the reduction is looking pretty good. And this is a 3 months follow-up. It has healed well. She was allowed to weight bear and walk. And this is at 1.5 years follow-up. No AVN. So that is a good thing about it. And the patient came purely to ask whether the implant needs to be removed. And that we previous practice was that we never removed implants in slip capital femoral epiphysis. We told that no need to remove the implants and they just disappeared for follow-up. And if you look at the x-rays, I'll come to it later. So 11 years later, she got into medicine and then into anesthesia. She's doing a second-year anesthesia residency. And she developed severe pain in the right hip and she's not able to work in the operating room. And the pain is so severe that she came on a wheelchair to our OPD. And this is the X-ray. So if you look at the X-ray, there are subtle signs of femoroacetabular impingement. There is not a lot of degeneration. The joint space looks reasonably all right. So this is a typical femoroacetabular impingement following a treated slip capital femoral epiphysis, which was not very severe. Now, the reduction was looking pretty good. And within just 11 to 12 years down the line, she became symptomatic. And we had to go and do a osteoplasty, relative neck lengthening and varus osteotomy. She's about 1.5 years down the line now. She's asymptomatic, but we do know that the cartilage in the hip when we opened up was not looking great. So going back, why did this happen? So if you look at the X-ray at 3 months, this is at 3 months post-op and this is at 1.5 years post-op. So clearly you can see that the lateral end of the sourcil is upsloping here. So this is in retrospect, when we look at this, this is not a great thing to happen. So in the follow-up X-rays, whenever you see that this is happening, and it is an indirect sign that the patient is having a clinical impingement, which is not symptomatic at that point in time, but it is bound to become symptomatic in the years to come. So can we do anything to prevent this from happening? So if you look at the pictures to get an idea of how a mild slip is worse than a severe slip. In mild slip, you see that I'll play it again for you to see that is a bump. It's a very small slip, but it is pinching the labrum whenever you flex and internally rotate. So, but whereas in a severe slip, this is a severe slip, it doesn't go inside. So the slip is so bad that it is not going inside the acetabulum. So we call it as an inclusion cam, where the prominent neck metaphysis actually pinches the labrum and goes inside. So this is what happens when the slip is mild and you have an impingement. You can have symptomatic femoroacetabular impingement later on, which can lead on to early osteoarthritis. So how can we prevent it? So we just have to open up and remove the bump which is impinging, which we call it as osteoplasty. So this actually gave us the idea of starting to do what we call as controlled repositioning with primary osteoplasty for unstable slips. So I would like to clear the differentiation between reduction and repositioning. So with reduction, we actually always say and use the term reduction for fractures where we are looking at getting a perfect anatomical reduction when there is a displacement. Whereas repositioning is a gentle maneuver in which we are trying to reposition the femoral epiphysis to the pre-acute slip position. We are not trying to get a perfect anatomical reduction. So that is why we prefer to call it as repositioning rather than reduction. So the rationale of this technique is that most of the unstable slips are acute exacerbations of chronic mild slips. So that's what we feel. And most of them are amenable for repositioning, where you convert a severe slip capital femoral epiphysis to a mild slip by repositioning. And you can add on an intervention to prevent future FAI, which is the osteoplasty. We'll show it through an animated picture. So this is a model of a mild chronic slip. You can see that posteriorly there is a new bone formation. There is a slip here. The neck is prominent and the vessel comes posteriorly. So when the patient develops a trivial fall, an unstable slip happens. So this is what happens exactly. So when in repositioning, we try to bring it back to the pre-acute slip position and not a perfect anatomical reduction. We know that there is callus posteriorly and getting a perfect anatomical reduction is going to stretch these vessels. So we don't want that to happen. So we reposition it, fix it with screws, open up anteriorly and remove this bump, which is going to cause impingement. And this gives us an opportunity to actually decompress the joint. There will be hemarthrosis in unstable slips. It decompresses the joint. That is an additional advantage. And also you can look at the epiphysis, drill the epiphysis and document the bleeding of the head and document the vascularity of the head. So our protocol for unstable slips today is to take up to the patient to the operating room as early as possible. And we do a trial of controlled repositioning. We take a cross-table lateral view and then decide whether to do a modified Dunn's procedure or an in-situ fixation with primary osteoplasty. So the technique is to, now we don't use a fracture table, it's a radiolucent table. Gently internally rotate till the first point of resistance, then flex it up to 60 degrees and then extend. And this is how we take the cross-table lateral view. And then look at the amount of slippage. So no forced internal rotation, no fracture table. And if you're able to get a decent reduction like this, where the head neck angle is less than 30 degrees and slip is less than 33%, then we go ahead and do an in-situ screw fixation. Check for flexion internal rotation. If the flexion internal rotation is less than 50 degree, you have to go ahead and do an osteoplasty. And if it is more than 50, just a capsulotomy is enough. The other limb will be where you are not able to get a repositioning like this. If you're an unstable slip and you try a gentle or controlled repositioning, and if you're not able to get a satisfactory repositioning, then you should be prepared to do a modified Dunn's procedure. So that is what we do in our institution right now. Just a couple of case examples. This is a 14-year-old boy, sudden onset of pain and unstable slip. So this is before reduction and this is after repositioning. And that is after 2 screw fixations. You can see the prominent neck metaphysis here, which is impinging. And that is after osteoplasty. And that's a 2-year follow-up of the same patient. So this is a series, this was about 2 years ago, I think. We had 38 unstable slips, out of which 14 were amenable for controlled repositioning. And all 14 needed osteoplasty. So which means that all of them were acute on chronic slips. None of them were acute slips. And we had 1 AVN in this series. After that, we have a couple of AVNs even in controlled repositioning. There is 24 in whom we were not able to reposition, had modified Dunn's procedure. And of that also, we had about 5 AVNs. So we published this technique, 2 papers. We did have complications. So initial protocol was to use just 1 screw for unstable slips. So we had 2 patients who had screw breakage, because they started weight bearing against advice. So usually we keep them non-weight bearing after fixation in unstable slips, but they started weight bearing and had a screw breakage. This particular patient, actually, we revised it. We removed this broken screw and did a modified Dunn and fixed it well. He went on to heal well. The other patient is still walking with the broken screw. He never came for follow-up after that. We had one avian. This is a patient who developed a sectoral avian. This is the only patient in the first 14 cases. So this is yet another patient, again, acute on chronic slip. You can see that there is some callus posteriorly. So this is a very clear case of acute on chronic slip, and we do not expect repositioning, but we did attempt controlled repositioning for this patient, but it didn't work. So we had to do a surgical dislocation, open up, and you can see how severe the slip is. And this is how you see an acute slip when you open up. And there's no way that you'll be able to reduce this because there is posteriorly so much of callus, and close reduction is going to be a disaster in this situation. So this is after repositioning, and that is just the epiphyseal drill hole to show a nice bleeding. So whenever you see this bleeding, you are at least peaceful to sleep that night that the epiphysis is going to survive, which is not true. So even if it bleeds well, sometimes you have seen that it can go on to AVN and collapse. So this is 6 weeks follow-up and 1 year follow-up of the same patient. So that finishes unstable slip. Low-dose classification is clearly insufficient to define unstable slip. So we should look at the onset and clinical features, the radiological features, and decide whether the slip is going to be stable or unstable. And intraoperatively, once the patient is taken in, you can see under the Shyam whether the epiphysis is mobile. Hemarthrosis, again, a subtle indicator that it is unstable slip. And controlled repositioning is definitely an option. That's what I personally feel. So it is about 20% of the unstable slips will be amenable for controlled repositioning. The rest might need a modified done. And we saw that one screw is not sufficient. It's better to use 2 screws for fixation. And arthrotomy and osteoplasty is definitely useful to prevent FAI in the long term. Let's move on to stable slip. So what do we mean by stable slip? Stable slip just means that the onset of slip is very gradual and it is a chronic event. Usually, the typical patient is an obese patient walking with an externally rotated limb into your outpatient department. That is our typical stable slip presence. The moment they walk inside the clinic, you will be able to recognize the patient is having a slip capital femoral epiphysis. And as far as the stable slip is concerned, the decision making is even more difficult compared to a frank unstable slip, because it is both of these patients. If you look at, we have 2 different patients with stable slips. The patient on the left has got a very mild slip, and the patient on the right side has got a severe slip on both the sides. So both are stable, but obviously both are not the same, and both cannot be managed the same way. That is why I'm saying that it is difficult to decide what to do in a situation with unstable slip. So how we treat stable slips today is we decide based on flexion internal rotation. FIR is we flex the hip to 90 degrees and internally rotate and see. So if it is the deformity, which is actually an indirect indicator of how much the slip is and how severe the slip is. If it is less than 20 degrees, we categorize this as mild slip. And if it is more than 20 degrees, we categorize this as moderate and severe slip. Also, you look at the radiological parameters. There are slip angle, head neck angle difference. So all those parameters we look at and categorize between mild and moderate to severe slips. If it is a mild slip, it is very straightforward. We can do a in situ screw fixation and primary osteoplasty. So like how we saw in unstable slip. So that is what we follow. And if it is a severe slip, we have to look at the status of the physis. So we do get patients who come with a closed physis because they have been walking on it for about 2-3 years and they come very late when it becomes really symptomatic. So if the physis is open, then we plan to do a modified dense capital realignment procedure. If the physis is closed, we treat it as a heel slip, and we will discuss about it a little later. So this is the same patient whom I showed previously, the mild slip on the left side. So this is a video which we showed the bump pinching the labrum here. So this is a simple Smith-Peterson approach to open the hip joint, and this is after osteoplasty. So we use a high-speed burr to remove the bump, and you can see that after removing the bump, there is space between the labrum and the neck, and when we flex and internally rotate, there is no impingement, and the labrum is actually breathable. It is not crushing it anymore. This is the post-operative X-ray and 2 years follow-up X-ray. This is a patient clinical pictures. decent range and he's able to do most of the activities. Moving on to heel slip. So we divide the heel slip. Heel slip means that the physis is closed completely. So, and we have to look at the severity of the deformity in the neck, which based on which we take decision. If there is no severe neck deformity, my preference would be to do a valgus osteotomy and an osteoplasty. And if it is the neck is completely deformed, then it's very difficult to do a valgus osteotomy in those situations. Then we decide to do a modified dense neck osteotomy or a derotation osteotomy later on distally. So I will show some of the case examples. So this is a 20-year-old male who presented with a untreated slip capital femoral epiphysis. So of late he developed increasing pain and stiffness. So this is a 4 years history. And you can see how the deformity is there. The plan here, the deformity is, the neck deformity is not too bad. The physis is completely closed. So the preference is to do a valgus osteotomy. That was what was done through a surgical dislocation approach. We went in, so did an osteoplasty and a valgus osteotomy and fixed it with DHS. And that's the 1 year follow-up X-ray shows that the osteotomy is pretty healed well, and he's not having impingement clinically, but still the flexion internal rotation is about 10 degrees. We are not getting more than that, but he's asymptomatic and his range is decent. On the contrary, if you look at a different patient, this is an 18-year-old patient, again, just a 1 year history. But if you look at the neck, it's completely deformed. This is also a heel slip. The physis is closed, but if you look at the neck, in the CT scan cuts, you can see that the neck is completely deformed. So we call this as a banana neck deformity. And when the neck is completely deformed, it is very difficult to do a valgus osteotomy by getting a hold into the head. So you can do a valgus osteotomy by putting screws just into the neck without purchasing the head. It is possible to do, but in such a severe case, I personally prefer to do a neck osteotomy where you correct the deformity at the cora. So we do a modified done osteotomy, which is slightly technically different from a capital realignment procedure, but the principles are the same. So this is a 1 year follow-up of the same patient. On the opposite side, we just did a in situ screw fixation with osteoplasty. And fortunately, he did not have avascular necrosis. He had a decent range and he's doing well. And finally, about prophylactic pinning. So we know that the incidence of contralateral slip in a patient with slip capital femoral epiphysis is about 20%. So this is an epidemiological study where they showed that it is more than 2,000 times more likely to develop a slip in the contralateral hip. And there are enough articles to say that the prophylactic fixation is safer than continued observation. So because most of the times the contralateral slip is an unstable slip, and we know that unstable slip has got higher complication rate than stable slips. So it is an easily avoidable, potentially disastrous complication. And there are a couple of papers about risk-benefit analysis, and clearly it is a low morbidity procedure with a high prophylactic benefit. So these are all papers which I published earlier. And if you look at the pros, definitely the main pro is it is going to for sure prevent the future slip. But the disadvantages, potential disadvantages are it could stops the growth, it alters the proximal femoral morphology, it's an additional surgical procedure. And there are reports of case reports of AVN and chondrolysis even after prophylactic fixation, which are anecdotal. I don't think it is a common happening. In our institution, we offer prophylactic pinning to all patients who present with subcapital femoral epiphysis. And if the patient agrees, we usually do it. And we did a small study to look up what happens to all these hips who were prophylactically fixed. And we could get 58 of these patients who have completed skeletal maturity. And we found that all of them kept growing. Then the neck length actually increased by 8.6%. The femoral offset also increased. The only thing which was decreased was articulotrochanteric distance. So that trochanter keeps on growing, the neck is not growing. So there is a mismatch. Neck is growing, but there is a mismatch in the velocity of growth between the neck epiphysis and the trochanteric epiphysis. So you have a decreased articulotrochanteric distance. And the neck shaft angle between was completely maintained normal. So that there was no change in the neck shaft angle. So we did not have any complications in any of our patients except one patient who had a drill bit breakage during a prophylactic screw fixation. That is the only patient out of 95 hips which had a complication. Otherwise, there was no problems. This is just to show one case who the screw missed the epiphysis and the child kept growing. And this is a 10 years follow-up. You can see this doesn't happen often, but it can happen. Sometimes it escapes, the physis escapes and it doesn't fuse. So we concluded that the prophylactic pinning does not stop growth of proximal femur completely. Only parameter which changed was articulotrochanteric distance compared to the contralateral hip, it was less. And though we expect the patient to have a Trendelenburg gait when the articulotrochanteric distance decreases, we did not see that in clinical practice. We don't see it often. The patients are completely normal. They don't even have a Trendelenburg sign, even if you do a stress Trendelenburg test. So with that, I would like to summarize. So definitely we need a better definition to differentiate between stable and unstable slip. The definition given by Lauder is no longer practically applicable. And unstable slip, there is definitely a role for controlled repositioning. Primary osteoplasty is a simple intervention which is helpful to prevent future femoroacetabular impingement. So our short-term outcomes are good. We need to wait for long-term studies to look whether that really works or whether it's just theoretical. Modified Dunn's procedure definitely has a role in treating slips, but it has got a steep learning curve, and we should be aware of the complications that can happen. And stable slip treatment is based on severity and the nature of the physis, whether it is open or closed. And prophylactic pinning is safe, indicated in patients who are young. Generally, we call it as younger than 13 years. Patients who are having obesity and endocrinopathy, it is better to do prophylactic pinning. Thank you for the kind attention. And I think the controversies as far as slip capital femoral epiphysis is concerned is never ending. So, I hope I did not confuse you all more than what is required, and I'll be happy to answer questions.
Thank you. Thank you, Dr. VENKATADASS. Can you please stop sharing your screen?
Yeah.
I think that was an excellent, summary of management about slip capital femoral epiphysis. At least I could educate myself a lot of things from your lecture. And before handing over to Dr. PADMAN and Dr. ANIRBAN and Dr. RUJUTA, I have just two small questions. First question is that you always use a fully threaded canceller screw, or you prefer to use a partially threaded canceller screw?
So if it is an in situ fixation, it is always fully threaded screws. If it is a modified Dunn's procedure where we are looking at compression, I prefer to use short threaded screws, the ones which we use for fracture neck of femurs.
And okay, the second one is that you do modified Dunn's procedure through which approach? Do you go by Smith-Peterson or you?
Ganz safe surgical dislocation approach.
That's what I was asking you, that whether you do the.
So the modified Dunn's procedure, the Dunn's modification, the name modified Dunn's is given actually by Professor Ganz. The original Dunn's osteotomy description was also done by a trochanteric flip osteotomy approach. So Dunn never did it through Smith-Peterson approach. He always opened up laterally, did a trochanteric flip osteotomy, went into the hip, and then repositioned the epiphysis. The only modification between the original Dunn's procedure and the Ganz procedure is Professor Ganz actually studied the vascularity in detail, and he described the retinacular flaps, how to raise the flaps.
Okay. Thank you. Thank you very much. Over to Dr. PADMAN. Dr. PADMAN, you are there?
Yes, I'm there.
Yeah. Now you can generate some discussions. We have next, 15-20 minutes. Over to you, Dr. ANIRBAN and RUJUTA.
Thank you, Venkat. That was a very nice summary of.
Venkat, with regard to your control repositioning,
There's a little bit of a lag in what he's saying and all, but go on, Manoj, we'll wait for your question.
Yeah. So can you hear me now?
Yeah.
Yeah.
Venkat, with regard to your control repositioning, I mean, is it, you said you don't use a fracture table. I mean, can you elaborate on the technique? Is it, how do you do it? Is it, and especially for something much more milder and gentler?
Yeah. So we don't put it on a traction table like what we use for fracture neck of femur. Typically, we put it on fracture table and give traction and internally rotate. That is how we are trained to reduce fracture neck of femur. And I'm sure all of us have done that for slips, maybe like 10, 15 years ago. But in this, we position on a radial loosened table and gently internally rotate the affected limb. So before even going to the maneuver, so what I typically do is bring in the C-arm and see in the external rotated position how the epiphysis is there, both AP and lateral. And then we document how it is, what is the status of the slip, how much is the slip. And then we gently internally rotate the limb, bring it to neutral. At the first point of resistance, we stop. We don't forcefully internally rotate and take the hip into flexion, about 60-70 degrees of flexion, and then bring it back to neutral position. And again, bring the C-arm and check the AP and lateral. And you'll be able to appreciate if the position has changed or not, definitely. And it could be challenging at times to measure the angle, whether it is like exactly 33%, 30%. So that decision is a little tricky, but we always measure the angle and decide whether to go ahead with an in situ pinning or open up and do a modified dense procedure. Yeah.
So just carrying on from that. So if you decide to do a Dunn's procedure, then at that point you will turn the patient into a lateral position.
Yes.
And then read it.
Yes. See, but what happens is, I mean, a lot of people ask me why not. Even Sandeep always asks why not you do a Porsche technique. So you open up anteriorly and reduce. So you are doing a closed reduction. Before that, you can open up and gently do the gentle reduction in open fashion. But I felt that that actually takes away the opportunity to do a modified. And if you open up anteriorly and if you're not able to reduce, and I'm not someone who believes that you can reduce a chronic, acute on chronic slip from anterior, because there is a lot of callus posteriorly. So all of us who have seen how difficult it is to reduce an acute on chronic unstable slip, we all know that it is not possible to reduce it from, at least I don't believe that it can be reduced from anterior just by opening up.
So lovely lecture, Venkat, as usual.
Thank you,
So
ma'am.
I'm going to set the cat among the pigeons, and I'm going to have your take on this and even Dr. Mohanty's take on this, that hip preservation and modified Dunn's and CAM and all that, they're more of X-ray radiological diagnosis. And we are actually perhaps generating more patients for arthroplasty. So are you increasing Dr. Mohanty's work in future or decreasing his work in future? What is your take on it and what is his take on it? How has practice changed in the last 5 years?
Or delaying the arthroplasty?
Well, that's a very good question.
Postponing
So,
the
FA is not a radiological diagnosis. That is the first thing I want to clarify. FA is always a clinical diagnosis. So radiologically, if there is a CAM or pincer, we are not going to treat that unless the patient is having a corroborative clinical symptom. And the girl which I showed, she's just 22 or 23 years, and she became symptomatic. She's complaining that she's not able to work in the operating room. She's doing anesthesia residency. And I think that at that stage, when the joint space is reasonably okay, there is definitely a role for hip preservation. I don't think hip replacement is an answer for her. We can postpone the hip replacement by at least 10, if not more.
No, I'm not talking in relationship to that one patient or similar younger patients. I'm saying the subject in general.
I mean, none of us are treating asymptomatic patients. I think very, I would say that if there is an obvious subluxation, then we would like to intervene. Otherwise, hip preservation as a specialty, The dictum is to treat symptomatic patients. Our incidence of primary femoroacetabular impingement as well as dysplasia is way much lesser compared to the West. So FAI is a big business in the West. The number of scopes they do and the number of PAOs they do is very, very high because they get so many symptomatic patients. The children are athletic. They all get symptomatic primary FAI when they are 14, 15 years. And that is not the case here. So what we are getting to do in hip preservation is most of them are secondary FAIs due to either Perthes or post-septic or slip. Primary FAI, I mean, it's very, very rare. I think same experience should be with MANOJ and ANIRBAN as well.
Yeah, I agree to that. I mean, there are very few patients who present predominantly with a hip pain, and you would diagnose an FAI which is significant enough to do a big sort of a surgery. And it's mainly, like you rightly said, mostly the secondary FAIs which we commonly come across.
What's your take, Dr. Padman and Dr. Mohanty? Since last 5-10 years, this is being spoken about again and again. So let's hear it from the arthroplasty surgeons as well and the pediatric hip surgeons who've been doing volumes.
I think the question is a little kind of, controversy provoking. It's not either or there, isn't it?
So that's why we are meant to clarify the controversies and get a consensus.
No,
really, where there is.
I think your net is little slow. Can you switch up the
Manoj,
video?
your
So
network is a little disturbing.
hip is not. Okay. Are you able to hear me?
Not clearly.
There is a little bit of lag in your audio, Manoj. Can you switch off your video?
Yeah. Is it?
Try switching off your video. That will give you some bandwidth on the audio.
I have switched video.
Yeah, okay. Let's try that now.
Go ahead now.
We can't hear you.
Yes, it's good.
Today,
Yeah, I think go ahead till then, Dr.
till
Mohanty.
Dr. Manoj comes there, from the arthroplasty surgeon's point of view, it's always better to operate a virgin hip rather than an operated hip with osteotomy done. First thing is that there will be some difficulties encountered on the table. Number two, chances of infection is more. And number three, the long-term outcomes would be poor in an operated hip rather than a virgin hip. But having said that, if you do a osteotomy, then at least the patient can have a pain-free life for at least 10 to 15 years. Then nothing like it that you are postponing or you can avoid one revision at least in his or her life. So if you are operating a primary hip, say at the age of as a teenager or maybe 20 or early 20s, then you are inviting at least 2 revisions in the life of that patient. So by doing a osteotomy, by retaining the native hip, probably you are avoiding 1 revision in his or her life. That is my contention. But it's always easier and it's good and giving a very good outcome in a primary, patient or primary hip where it was not been operated earlier.
Yeah, so we try to keep it simple and we don't disturb the morphology and make your life difficult as much as possible. So that is the beauty of all these advanced procedures, where you medialize, lateralize, bring the trochanter down and all that. So the morphology doesn't change much. So in the previous case, which I showed also, we did a varus, but there is alignment still looks good enough for you to put a stem inside. There won't be much of a difficulty.
Okay. Manoj's viewpoint, the ANIRBAN, yeah.
Yeah, I have just a couple of quick questions just to clarify for our audience. There is always this controversy about the material of the screw nowadays with regards to titanium versus stainless steel. So for your audience, could you clarify whether to use a stainless steel screw for the stable in situ ones or even for the modified done ones? So what's your preference and why?
I always use stainless steel, and for the question why, I really don't have an answer. We have been using it as practice, and we just continue to use it. We don't have any. I don't see any disadvantage of using stainless steel, although there is a theoretical advantage of you can take MRI if you put a titanium screw in. We started using it in between, but then somehow I did not find the real need for it, so I did not change over from the age-old practice of using stainless steel screws. But I don't think it makes any difference. You can use whatever you're comfortable with.
Manoj, your preference?
I think the originally the titanium screws came in with this so-called benefit of MRI. I think now the pendulum has swung towards stainless steel reverse cutting so that it's easier to remove. That's the only thing. Ultimately you want sufficiently long and sufficiently threaded screws. So stainless steel, I think universally most people prefer for slips now.
Do you remove all the screws, Manoj?
I don't routinely this thing. I think a few years ago, I would say never to remove. Now I am a little bit more where I think where they are a little bit more prominent. I leave that, I kind of give them the option. But earlier, I think the ones which I used to pin 10 years ago and all, I just say I don't remove it.
There also, I think the pendulum is swinging back towards removal, considering the later total hip replacement in mind.
Yeah. I think so we should leave some work for Dr. Mohanty, some hard work to justify his.
No.
So yeah,
I'll tell you, nowadays somehow or other I am preaching for removal for all the implants, not only this type of screw. For even trauma surgeries, after you do trauma, whatever the fracture has united, and maybe 2 years down the lane, I think we should remove the implants. So we are seeing more and more now implant related complications like broken implants, backing out of the screws, rather than doing it as an elective manner and taking it out after the job is done, keeping it, postponing the problem, and later on, whenever it is required, you are going to take that time. Life becomes so terrible that to take out this implant, a long period of surgery and all, and then chances of infection is more. So now I am putting it, though it is a little controversial, but wherever I'm talking about in favor of take out all the implants after the job is done.
At least periarticular implants. That's what you mean.
Yeah, periarticular implants, of course, periarticular. And stress fractures also. Even the plating has been done. You will see, suppose 15 years down the line, there is a stress fracture. That time, removing the implant becomes so difficult. You will do more harm to the bone and the surrounding soft tissue structures, rather than doing a better job during that time.
But I have one point against that as well, because we've had these problems. I'm sure all of us have faced these problems. And nowadays, with the locking plates and screws, sometimes even if you want to take them out within the normal period of time, say 1.5 years after the job is done, sometimes it doesn't come out.
Yeah.
So then it becomes again a challenge. You ask the patient to come in for an elective procedure, and you are unable to take out the implant. And if you want to really take it out and do a further osteotomy and do that, that's a little, it goes against the principle of primum non nocere. So I am still a little not very comfortable with doing that.
But any of the implant removal, we always take a concern that there is a possibility of partial removal, possibility of inability to remove the thing, in possibility of further fracture of the bone, that we take all these concerns. But if again, looking at that thing, that if you're unable to remove at 1.5 years, what about 15 years down the line? You're just postponing the problems.
I think if I can come in on that, RUJUTA's earlier question about, about hip preservation versus arthroplasty. As I think Dr. Mohanty alluded to, we're not talking about either or, because traditionally, historically, most of preservation work, at least 10, 20 years ago here, was amongst orthopedic surgeons, was primarily on the fracture necks in the young adult and avascular necrosis. Now, those are two different entities. Those, yes, there is always a debate in those. What do you do in the Ficart pre-collapse stages and all that stuff. Now, in these are childhood pathologies which we know have, longitudinal studies have clearly shown that they will end up having premature arthritis at some point. Now, if we can kind of preserve that hip without distorting the morphology, and that's where, a lot of work which we are now doing, as Venkat alluded to, like, a lot of acetabular work for dysplasia, very less femoral distortion, for something like a safe surgical dislocation and a modified done, there is very little femoral distortion. You're bringing the flipping the trochanter and just fixing. There is no, you still can put a straight stem down there. Yes, it is an operated hip, but we don't really distort the femoral side. And I think, correct me if I'm wrong, Dr. Mohanty, if we had to kind of, arthroplasty surgeons do not want the femoral morphology to be grossly distorted, whereas acetabular bone stock, anything which is done even in dysplasia, or anything which is done there to preserve bone stock will help the future hip arthroplasty. So I think realistic, this thing would be like, if we can save at least one revision for that particular individual, that's probably a realistic kind of aim. So to leave them to kind of, say, okay, that's fine, and carry on until it become painful. And, and we see a lot of these children and a range of pathologies, late teens, early 20s, having severe pain. And that's, and if something can be done at that stage to kind of give them at least, a decade and a half of pain-free existence, that's worth it. So it's not either or there, and it has to be complementary.
And in the years to come, I think it is going to increase the number of hip preservation procedures, and that is, that is how it's going to work out. That's the nature's way, I guess.
I agree with Venkat that, as long as your cartilage is intact, you have to do hip preservation surgery. Once cartilage is gone, then of course
no preservation.
No preservation.
Yeah. So that is the dictum we follow all the time. So no cartilage, no preservation. That we say, they teach all the time. Yeah.
ANIRBAN,
Yeah, one question for Venkat regarding the POSI survey which you mentioned in your talk. Well, that survey was done in 2013, I guess, and you were thinking about redoing the survey. Is it related also to the level of expertise amongst our POSI members as well? I mean, in 2013, 10 years back, compared to what it is today, not very many of our POSI members were familiar with hip preservation procedures. And like you rightly said, there is a steep learning curve. So maybe if we repeated the survey now with a growing number of surgeons who are more proficient with, say, surgical dislocation, would that be a reason of change in the preference of the options given in the survey?
Exactly. Because see, we 2013-14, hardly anybody was doing modified done in India, right? Nobody was. Very few people were started doing at that time, probably. But then, even in that scenario, 25% of them opted for modified DUNS procedure. See, if you look at the number of people who responded, it was like 94 people out of, I think it was 350 or 60 email IDs we had at that time. Out of that, only 94 responded to the survey. And in that 94, 25% opted for modified done. I'm sure we don't have to do a survey. I'm sure now if we ask this, do the same survey, 90% will choose for modified done. Very, very few will go for closed reduction, I guess. Yeah. So even in meetings, when we talk with each other, we know that who are all doing closed reduction, who are all doing modified done. So the scenario has completely changed in the last 1 decade. Things have changed in a big way. So safe surgical dislocation is no more a very complex procedure. It's not a rare surgery which is done very rarely. So it is like a routine surgical approach for the hip joint for us now. It is good, actually. It is a positive change which is very much needed for our patients. That's what I feel.
Okay. So as a corollary to that, since a lot of general orthopedic surgeons would also be watching this program, and some of them would probably be treating these, or at least seeing these patients for the first time, what would be our message to them with regards to, because they may not be comfortable with a modified done or say surgical dislocation approach. So would it be okay for them to go ahead and do a closed reduction, or should they just refer straight away? Because that 24-hour, since you mentioned and shown that that 24 hours is no longer that critical, because standard book teaching is still that, you know, you have to try and do it as fast as possible. So they may be in a hurry to, like, this is like a fractionate femur, we must reduce it within 6 hours, 8 hours, or else we will get AVN and we will be blamed by the patient relatives, etc.
So I think the message here would be, if the surgeon is not comfortable of doing modified done by himself, and if there is a nearby facility which is available, and if the patient is also willing to go, I think the best thing would be to refer to that center. But on the contrary, if there is no nearby facility, or the patient is not willing, not in a position to go, there is no harm in trying a gentle repositioning. And even if you don't get a reduction, it is okay to fix it with in situ screw fixation. Whatever repositioning you're able to get, just accept the reduction. Don't try forceful reduction. Put a screw and fix it, couple of screws and fix it. And we can deal with the other problems of femoroacetabular impingement later on. You just have to warn the patient that this is not the end of the treatment. You will have to have regular follow-up. You can become symptomatic later on, and you might have to have surgeries later on to deal with the femoroacetabular impingement. So I think that is the best way to go with unstable slips. Stable slips is a different ball game. I mean, if you ask me, even today, I'm not very sure how to decide between a moderate and a severe slip. Mild slips, it's one category. We know that it is mild. We do an in situ screw fixation, and with the primary osteoplasty plus minus, it's depending upon your comfort levels and the patient's consent. But between mild and moderate, I mean, moderate and severe, the severe ones, also whether the physis is open or closed, there are a lot of variables in that. So I think it is better if you get a moderate or a severe stable slip. I think it is better to refer to an expert who does this on a routine basis.
Talking of the
Just
stable
RUJUTA,
but
one
mild.
before
Yeah,
that,
just
Dr.
one
Manoj
question.
had some question. Yeah, before.
Yeah, I mean, I just had a comment on that, where there is, in answer to Anirban's question, I have a slightly different take from Venkat there. I mean, Venkat works in Ganga, where the numbers are big and they are able to do this positional reduction with all its due precautions. Most orthopedic surgeons would interpret this as a fracture and would treat it like a fracture. So I would urge them to, if you do not have the skill set available or the resources available to deal with it, pin it in situ. Which is much more safer. Pin it in situ and whatever once, so that you minimize the. It is still an accepted standard, so long as we understand what the limitations of it. Pin it in situ, and then once it's all healed, deal with it later.
Yeah, in situ pinning, Manoj. So you want to do the in situ pinning with the limb in external rotation or neutral rotation?
Yeah. So therein comes that gentle pose. Yeah.
So most of them who do the in situ pinning will rotate the position, limb to neutral position, where you get the reposition. That's what I feel.
So my question is actually in relationship to this only, that between the mild and the moderate stable slips, because of this external rotation, it's very, for a novice or somebody in the learning curve, very difficult to judge, especially if you're trying the foveal screw, of how deep you have penetrated. You want a textbook picture, and you're always a little either insecure when only 3 threads seem to have crossed, because the physis has slipped. So your exact trajectory of getting that one beautiful looking foveal screw doesn't always happen. And either you penetrate too deep or you remain too superficial, and then physis continues to grow and your implant backs out. And then you're still worried whether this is going to now slip in future, because now you've added the instability. So any tips for our learning curve, how to judge that placement on table of, are you too deep into the cartilage or you're like just enough?
I mean, I think most of the patients are old enough for us to see the subchondral bone properly. You can see the femoral head margin. And if you aim to get center on AP and lateral, I think it is good enough, ma'am. So what typically happens with most of us, we are trying to use cannulated screws. The Indian cannulated screw system, the guide wire is very thin. So we will direct in one direction, it takes its own direction. So that is a problem why we are not able to get the fovea center probably. So that is why we started using the 4.5 drill bit directly to drill. Instead of using a thin guide wire, we use the drill bit. Otherwise, you should use the original Synthesis set cannulated screw where they have a thick guide wire. So if the guide wire is thick, you will be able to direct in the direction where you want exactly. So my take on this is to use a 4.5 drill bit directly, which gives more control regarding the direction, in both the planes.
I think
No, I mean, as in, don't you use techniques like placing it on the skin first and just really checking?
Yes, ma'am.
So that's the kind of tip I wanted you to give to the audience.
Okay. So, I mean, there is a nice article which I posted, showed in one of my slides, which is published in IJO, how we do an in situ screw fixation on a radiolucent table without a fracture table with the patient in supine. So in the CM, so the entry point is pretty straightforward. If there is a mild slip, we have to go a little anterior. And it is usually 5 millimeters below the trochanteric apophysis. That is the starting point. And we keep a guide wire over the skin, and which will give you a rough direction of where you are going to drill. Then we make the skin incision, and we use the drill bit directly for drilling. And I personally don't use the guide wires actually. And you can take a frog-leg lateral view easily by abducting and externally rotating the limb. You don't have to have the fracture table and don't have to rotate the CM. So we have written up nicely. It's a 10-step guide which we have published already. It's a very simple and easy technique to learn and do for the beginners who are learning to put in situ screws.
Gentlemen, we are running out of time. So thank you very much for this beautiful episode of controversy in the management of slipped capital femoral epiphysis. So before I close down, just concluding remark, Dr. Manoj.
Slipped capital femoral epiphysis is definitely, controversial. Venkat's talk was brilliant in terms of telling us where the problems are. The key things are like, recognizing it, identifying it, diagnosing it early, understanding what surgical skill set and resources are available at your disposal, and deal with them appropriately. Wonderful interaction with all the panelists, ANIRBAN and RUJUTA, and to get another perspective from Dr. Mohanty about where it all end up finally as well. Very nice, interesting evening.
Thank you. Thank you. Dr. ANIRBAN, concluding remarks.
Yeah, I think it's a very nice ways Venkat has brought out all the knowledge gaps which are there between published literature, textbooks, and what we probably face in day-to-day practice. And how to decide between when you are on a patient, whether it is really a mild slip or a moderate slip. So there are these, and the more we read and more we learn, we find that we probably know a little less. So thank you, Venkat, for a nice summary. And yes, it was a very nice interaction with all of the panelists and coming to probably some consensus. I hope it will be informative for all our OrthoTV viewers.
Yeah. Thanks. Dr. RUJUTA, your concluding remarks.
So I think, Venkat makes it very gentle and easy, and that's how we expect the gentle reduction on table to be also. That is one thing definitely to remember for all orthopedic surgeons. Meticulousness in even surgery like in situ fixation is important, because if we trivialize it and think only of SSDs and FAIs, which are big surgeries, remember that half of it we ourselves have ended up causing. So actually, if you really follow each simple point also nicely, like he's alluded to in that article, a lot of our slips can be managed better than we already do. And I think most important message for the general surgeon, I mean, SSD, of course, they are the better experts. I myself have absolutely no claim on that, though there is a level of interest. But I think the most important lesson here is that we should not be looking at an SCFE exactly on the lines of a fracture neck femur or a transcervical. So making that distinction and realizing that the thought process in an SCFE has to be different is a very important lesson for all of us.
Thank you. That's how you gently handle the pediatric patients as well. Finally, Dr. Venkat, your concluding remarks.
Yeah, I think this was a great evening. Good to interact with Manoj, ANIRBAN, and ma'am as well. I think slip capital femoral epiphysis is, a never-ending controversy. There is no doubt about it. I try to make it little simple, and I did not cover the basic part. I thought we are talking about controversies, so I did not cover about how to diagnose. Always take a lateral view in an adolescent with hip pain, and most of the slips present with knee pain. So it is not hip pain. So all those basics I did not cover up in this, but we touched upon all the controversies which is existing now, and I think it was good to hear all the perspectives. It was a good experience, and thank you very much for the opportunity. I think I made justice, and I hope all the audience who have listened to the lecture today had some benefit out of it. Thank you again.
Thank you, gentlemen, and thank you, Dr. RUJUTA. It was really, from all the regions, east, west, north, south. So all over the India, the opinions, has been shared on this platform. Thank you for joining today, and we thank OrthoTV, Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, as well as Poonam for handling this episode of Controversy and Consensus. Now, finally, I hand over to Dr. DEEPAK GAUTAM to close the session.
Thank you all. Thank you for this nice discussion in this evening of Ganapati. So thank you all. It was very interesting session. For us, at least, Dr. Mohanty and me, we enjoyed a lot.
Yeah,
A lot. Okay, then we'll be back again after 2 weeks with new controversial topic in another field of orthopedics. Thank you all. Good evening.
Bye-bye.
Bye.
Bye.